Hello, Mind Bloomers. This is Mind Bloom, the safe space at the intersection of mental health advocacy and breast cancer awareness. Mind Bloom is your podcast. Subscribe to hear more on female entrepreneurship and the juggling of family life, career goals, and romantic relationships. Not an easy task, especially if your physical and mental health need a big hug right now. Hello, Mind Bloomers. This is Marina Gee, your host, and welcome to Mind Bloom, the podcast for all things mental health and breast cancer awareness. Before we dive into this week's episode, let me just say that Mind Bloom, the podcast, and the content at Mind Bloom U across all platforms is not intended to be a substitute for medical advice, diagnosis, or treatment. You should always contact your providers for medical counsel. Never disregard any medical treatment or delay seeking professional help because of any content authored or distributed by Mind Bloom. Hello, guys. Thank you for joining in. Today is not Tuesday, it's Thursday, and it's the first bonus episode in the month of October. So if you were already a big fan of Mind Bloom and you couldn't wait for Tuesday for another episode, this month is your lucky month because there is going to be 2 episodes a week. So just quit your job already and just, sit back, relax, grab a cup of coffee, and listen to Mind Bloom on repeat, constantly. I, for one, am very happy to have you on the other side. I'm also happy to be here by my microphone twice a week this month. It's exciting. And I bring you 2 interviews a week. I hope you enjoyed the first interview of this series with Donna Bragg. And today we have Dr. Jen Montes. Dr. Montes is a general surgeon specializing in diseases of the breast. She is currently with Hunterdon Healthcare in New Jersey, and she is as well the founder of Evolve Pink that you can find on Instagram at Evolve Pink. Dr. Montes and I have a really interesting conversation. We talk a lot about LCIS, or lobular carcinoma in situ. We talk a lot about early breast cancer, the breast cancer in people who are under 40 years old. And we are also going to bust a few myths around breast cancer. What causes it? Are we doing anything wrong? Are we eating the wrong things? Are deodorants killing us? So all those kinds of things. We discuss life after breast cancer, because that is a topic that is not often discussed, and that is exactly what Evolve Pink that she founded is doing. Evolve Pink tries to bridge the gap between the all clear that the breast cancer patient receives after treatments, after surgery, and the moment after all of this that has become natural and routine, all the doctors, the treatments, the follow-ups, when all of this stops, when all of this ends and the patient is left with maybe a different body, maybe with hair loss, maybe with weight management issues, with an early menopause, lack of libido, who knows, so many things that can happen, anxiety, depression. And these things are not usually talked about. One would imagine that getting the clear from the surgeon and the oncologist and the radiologist saying that you're good, the cancer is gone, you're in remission, or it was completely eradicated from your body, you would think that's great, amazing, spectacular news, and they are. But there are not enough protocols out there in place to facilitate the transition into this post phase in the patient's life, this moment post breast cancer, after breast cancer. This is actually also what MindBloom has been focusing on Instagram on Wednesdays. For the month of October, we're only going to be talking about life after breast cancer. Today, actually, I just released a post about life after breast cancer and relationships. What happens to your love life, to your sexual life, to your romantic life after breast cancer? Are you going to resume dating? Are you going to adapt and adjust to your new body and your new self-image? We talk so much of breast cancer before 40, and if that is the case, and you consider dating again, when is it a good time to have the cancer conversation? When is it a good time to have the double mastectomy conversation? If you have, and if you've been in a long-term relationship, what are your new needs? What do you wish for after breast cancer? What does your partner wish for? Are you communicating, the both of you, and establishing, who knows, different new boundaries? These are all questions that may not have answers, really, and each person will be different at addressing these issues. It should all be about time and patience and gentleness and being kind to yourself and giving yourself time to heal mentally, emotionally, and physically. After breast cancer, you have been through hell and back, and now more than ever, you deserve all the love and all the care, the attention, not only from others, but from you, especially from you, and to you, and towards yourself. So stick around to hear what Dr. Jen and I talk about in the next 30-40 minutes or so. Don't forget to tune in again on Tuesday next week, and then again on Thursday. Don't forget to follow MindBloom on Instagram. I'm so close to 1,000 followers. I think I have 15 to go. It could be you. MindBloom is at MindBloomU on Instagram, on Twitter, on Facebook, and Pinterest. And you can type it up on YouTube, and you will find all the interviews and the full episodes. It's great to put a name to a face. And you can shoot me an email at info@mindbloomu.com. And you can go check out the MindBloom's website. If you type mindbloomu.com, you will find it. All right, guys, I thank you so much for your company, for your attention, for the time you dedicate me and my guests and my ramblings about mental health and breast cancer awareness. I love you all, and I will see you again next Tuesday. Bye-bye. Guys, if you haven't heard about Anchor, it's the easiest way to make a podcast. Turns out it's free. There's creation tools that allow you to record and edit your podcast right from your phone or your computer. It will also distribute your podcast for you so that everyone can listen to it on Spotify and Apple Podcast and many, many more. And guess what? You can make money from your podcast with no minimum listenership. It's everything you need to make a podcast in one place. So go download the free Anchor app or go to Anchor FM to get started. Hello, Dr. Jen. Welcome to Mind Bloom.
Thank you for having me.
How are you today?
I'm good.
Yeah.
It's been a little crazy week, but I'm good.
I can only imagine. You just got out of the OR, you were saying. So thank you. Thank you for making the time to speak with us for a few minutes.
My pleasure. My honor. Thank you.
Yeah. So tell me, what makes your mind bloom?
My mind bloom. That's a great question. So, and I think it's changed over the years, but lately what's making my mind bloom is the idea of integrating more holistic services into the treatment of my patients.
Okay.
I really think that it's something that's been overlooked traditionally in medicine, to integrate those types of treatments into the treatment of patients in general, but certainly for breast cancer patients, because that's what I treat.
Yeah.
It's becoming more and more apparent to me as I get deeper and deeper into my practice that those modalities are an absolute necessity in the treatment of this disease, for women to be able to go from treatment to healing seamlessly. So that's kind of been my passion right now, and all of my brain children come from that.
Yeah, that's so interesting you mentioned that, because yesterday I was talking with a breast cancer patient. She's in remission now, but she mentioned, she was talking about the depression she fell into very deeply after treatment, after surgery, after treatment. You go through months of grueling therapy, and then you're left to your own resources, according to her. Yeah. So she is a big advocate for this not to happen anymore. And it's so interesting to hear you speak about that as well. So you do, from the medical community perspective, you do as well feel that there is a lack.
Absolutely. I think actually if you watch the Evolve Pink video, I think that's an actual line that I say, that these women, even though the treatment is grueling and it's a grueling time in their life, they have a lot of support by way of doctors, nurses, social workers, whoever it might be that's involved in their care. And when it comes to breast cancer, it's a multifactorial treatment.
Right.
And then, you come to the end of this treatment and you're kind of left hanging. I always thought, like in the naivety of my training, that the day I told my patient, you're cancer free, you're at the end of your care, that would be a really, monumental moment that we would hug, and it would be this big thing. And really what I was met with, and I realized very early on, it's that all of the worries that they have that have kind of subsided during their treatment are replaced in that moment with new ones. Like, well, what about tomorrow? What do you mean I'm going to see you in 6 months? Because these people have had a regimen of seeing doctors and nurses every couple of weeks, if not every day.
Yeah.
So that's the piece that I want Evolve Pink to fill, but not only fill, but to prepare women for that transition.
Oh, that is the best news. Thank you for doing that. And what, so you speak of a holistic view of the patient. So what things would you recommend as self-care? What are the things Evolve Pink recommends?
So we recommend a lot of things, and it's an integration. So I know, and I like to make that really clear, because sometimes patients seek me out thinking that I treat breast cancer very differently, that I don't do surgery and radiation and chemotherapy. And that's not true. I believe in treating breast cancer with the things that I know work to get rid of it. However, that being said, the integration of those holistic modalities helps women throughout that grueling process to just heal better and to be able to go through that process in a much smoother and healthier way. So some of the things that Evolve Pink has been offering is meditations. We've done some yoga series. We're offering yin yoga weekly. We've launched an exercise program. We're offering a different exercise program a day. We're doing body circuit weightlifting, bar, different things. We're also focusing on nutrition. I happen to be a pescatarian. I don't eat red meat. And there's not a lot of hard science, but I believe that reducing the consumption of meat is helpful for women in reducing the rate of recurrence in breast cancer. And it's good for you for other reasons also. So we host a Meatless Monday cooking seminar every first Monday of the month with our nutritionist, Nadia, who's wonderful. What else are we doing? We launched our preoperative Reiki program last night, actually, with our first patient. So we're going to be offering Reiki to our patients who are due for surgery. I perform surgeries on Thursdays. So Wednesday evenings, they'll go in, have a complimentary Reiki session the night before their surgery so that they're coming into that space in a calm, energetic way. What else are we doing?
You do makeup sessions.
Yes, we've done makeup sessions. We've done new moon ceremonies. We also host, aside from that, we host a lot of experts in their field to talk about some of the side effects that come along with breast cancer treatment. So we've had some experts come in to talk about pelvic floor issues, sexual dysfunction. We had a company called Bonafide, who I love their products. They're all natural, non-hormonal products that are used to treat vaginal dryness, to treat hot flashes, which is a huge issue for women going through breast cancer treatment, especially the younger women who are put into early menopause from their treatment. So we're trying to, keep our ear to the ground and listen to what women are experiencing and trying to bring the experts in that can help with those issues. And that's the goal, to educate, to empower, and to help women, even though this is, one of the more catastrophic things they'll probably face in their lives, to come out the other end, not feeling, depressed and destitute, but with hope and with some new skills and things that they can incorporate into their lives.
And also a new community of other women they can meet in the process. So who can join, who can benefit from Evolve Pink?
So anyone can benefit. A lot of what we're doing right now, which happened organically. So I'm glad that I named it Evolve Pink, because through this COVID crisis, it certainly has evolved. And right now, a lot of what we're doing, for better or worse, is virtual. And when this started, I was very disappointed about that, because we were about to lease a house and create our space, and everything turned virtual. But what I've learned is that our reach has become almost global. We're reaching women in Costa Rica, Australia. We were counting today with our grant writer. We've reached women in 41 different states. That blows my mind. And we just launched in March. So to me, it's just a testament of how needed this is in this community, to start integrating these things into this treatment. And to certainly create community for women who can meet women that are in similar situations to them.
That's beautiful. It's wonderful. Yeah, I visited the website, and you offer so much. And then I became friends with a few of the people who contribute to Evolve Pink on Instagram. So it's a lovely community. Everyone wants to help, and everyone wants to support each other.
Oh, let me not forget. We did a hair loss series in August, which was wonderful. And we collaborated with several women in the breast cancer community to help guide women from before, during, and after treatment of chemotherapy to how to deal with their hair loss. And I had no idea how many things come up for women, during that. So for me, I'm learning a lot too.
Just a quick question, a quick curiosity I had. Are you seeing in your patients more women under 40 by any chance?
I'm seeing a lot of young women, to be honest. I really am. Not many under 40, a few, but certainly women in their 40s. And that's why, to me, one of the biggest points I make is that breast cancer screening needs to start at 40 if you have no increased risk, which we could talk about, how to figure that out. And it needs to be yearly. It saves lives. When you look at the scientific data and the numbers, that's the age that saves the most lives. And there have been some groups that have come out and recommended that women start at 50 and every other year. But when I look at the numbers, I can't find a way to make that make sense to me. It needs to start at 40 and it needs to be every year.
Mine started earlier, yeah.
Yeah. So for women, especially women who have a family history, you should start 10 years prior to when that diagnosis was made. And there are ways that we can assess a woman's personal risk using different calculators that I use in my office.
Tell me more.
That take a lot of things into account. So when it comes to breast cancer, there's so many different risk factors that come into play. And women, being women, we want to know the reason for things.
Yeah.
And when a woman is diagnosed, especially a young woman who's healthy, it's not uncommon for me to sit and hear a woman tell me, but I eat well, I exercise, I've never smoked a cigarette. No one in my family has breast cancer. Why did this happen? And the truth is, I can never give them the answer of why that happens. It's just a combination of environmental, biologic, and maybe some genetic components that we just don't even know exist yet at work, at play. But we do have a way of inputting that information into these calculators, and it can give us an estimated risk of a diagnosis of breast cancer through your life. So things that you put in there are the age you started your period, when you started menopause, if you've had children, at what age you've had those children, the density of your breasts, have you ever had biopsies in the past, what is your family history, things like that. And those are the things that are put in, and it spits out a number.
Yeah.
And anyone who has more than a 20% lifetime risk, the general population, someone with normal risk, is about a 12% lifetime risk. Anybody with a 20 or greater percent lifetime risk is considered high risk.
Yeah.
So what does that mean? Depending on the level of risk, it means that we're at least watching you a little bit differently. And those women qualify for a yearly MRI, which has become a little bit questionable. There's some question in the literature about whether or not the gadolinium dye can cause issues. But there's no hard evidence to say that it does. But for women who are concerned about that, we spread their MRI maybe every other year.
Yeah.
And they're still getting the benefit of that really sensitive test. So the short of it is, if we know there's an increased risk, we have to watch women more closely, because our best friend in any cancer, but certainly in breast cancer, is early detection. The earlier we detect a breast cancer, the higher the rate of cure, the less amount of therapy they need. Oftentimes they wouldn't need chemotherapy, smaller surgeries. So it's just a benefit all around to catch things early by screening appropriately.
Let's talk a little bit about LCIS. As you know, I have a ton of questions about it. I was diagnosed with it in November, had a lumpectomy, and was then, it was suggested that I saw an oncologist, and they recommended tamoxifen. The prophylactic double mastectomy was always in the conversation, not necessarily this is what you should do, but just this is one of the lines of treatment you can go for. And supervision every 6 months is the other one. I'm not on tamoxifen. I'm still very confused about the whole process. And I understand it's not cancer, and I feel lucky because of that. I do, though, feel confused and conflicted about the fact that not being cancer, I still have the treatments, the options that women with breast cancer have ahead of me. Some of them highly invasive, right? Therefore, I would like if you could talk a little bit to us about LCIS.
LCIS, right. So LCIS has changed through the years, even while I've been in medical school and training. It used to be considered a precancer, and we used to treat it very differently than we do now. Now LCIS, which is sometimes confused with DCIS. So let's just talk about what LCIS is. So LCIS is lobular carcinoma in situ. DCIS is ductal carcinoma in situ. So the lobules are what the glands in the breast that make milk, and the ducts are the tubes that connect those glands to the nipple. So that's the difference of just where they start. So LCIS is not considered a precancer. It's considered now a marker of increased risk for making a cancer in the future. So, which can be a little confusing, mostly just because of the nomenclature, because they have the word carcinoma in it. That being said, just as you said, we offer a lot of the same things that a woman with a diagnosis of cancer would be offered for something that isn't cancer. And that confuses a lot of women, understandably so. It kind of circles back to what we were talking about before. It circles back to being able to identify women who are of higher risk and changing the way that we treat those women to avoid having a catastrophic cancer down the line that we can't do much for. So when I plug in somebody who has LCIS into those calculators that I was talking about, it usually comes up to be around 40%, give or take, right?
It's what that's what I have.
So given that, we have to measure, right, the risks and the benefits. There's still a 60% chance that you won't make a breast cancer, right? So for a lot of women who are offered a prophylactic mastectomy for something they have a 60% chance of not doing seems a lot, right? The tamoxifen is offered because we know that women who take tamoxifen, when we look retrospectively back at all the women who have had LCIS, and we compared the women who took tamoxifen and who didn't, the women who did take tamoxifen had about half of the rate of cancer diagnosis than the women who did not. Okay, so that's a pretty big benefit. That being said, it comes along oftentimes with a lot of unwanted side effects, especially for younger women. Hot flashes, vaginal dryness, some women experience hair loss, things of that nature. Some women experience nothing.
Yeah.
So what I tell my patients oftentimes is that if they're open to it, because it's such a benefit, it's 50%, it's a lot. It's not like 10%. It halves your risk, is to try it, because trying it doesn't marry you to it. If you're having a lot of the side effects that are unwanted, then we retract and, figure it out. It becomes a balance of what we're willing to deal with and the risk that we incur, right? Does that make sense?
Yes.
And everybody's different. Everybody has their own view of what they're willing to deal with. Some women would say that's too much risk and would opt for a prophylactic mastectomy because they don't want the anxiety really that comes along with having to be monitored every 6 months and possible biopsies every so often and things like that. So it does become a personal choice, and it requires a lot of discussion between you and your doctor to come to something that makes sense for you. Because at the end of the day, everybody, no matter what the diagnosis, has sovereignty over their body and has to be the final decision maker in what the treatment's going to be. So I see it as my job to give my patient all the information and then to support them in the decision that they make.
Yeah, it is complicated.
It's complicated.
I have 2 follow-up questions. Let's see. One has to do with tamoxifen. So you take it for 5 years, I believe.
Yeah.
Is there an increased risk again after the 5 years? So does the percentage of 50?
That's a great question. So do you take it for 5 years and then after 5 years, do you go back to your risk? No. Oh. So the 5 years that you take it, the benefit is seen throughout your life. There was some, quite recently, there was question about whether or not taking tamoxifen for 10 years had a benefit. Mm-hmm. And I think that the data shook out from that to not really make much of a difference. Sometimes women who are very young when they're diagnosed that are on it, I do see oncologists keep them on for the 10 years because somebody who's diagnosed that long, we just want that little added cushion. But the 5 years protects you forever.
That's good news.
That's good news. Yeah, I tell people it's your 5-year boob vitamin.
Oh my God. I mean, yeah, okay, I see. And then the other question is, in the case of a double mastectomy, does the woman is still at risk of, even if a little percentage of breast cancer or secondary breast cancer?
That's a good question. So unfortunately, nothing in the world of medicine or really in the universe is absolute, right? Mm-hmm. So no one can tell you have absolutely no risk, but it's the closest you can come to no risk, especially if you haven't had a breast cancer diagnosis before. So it reduces your risk of breast cancer to about 1% to 2% is what I've been reading in the literature. Mm-hmm. But that also means that you are 98 to 99% not going to make a breast cancer down the line, which are really good odds. I think the chances of making a breast cancer from LCIS diagnosis after prophylactic mastectomy, I've never seen that in my practice, to be honest. But I'm sure somebody out there has experienced that because that's just the way the world is.
Does LCIS become invasive if left alone, or is it a completely different?
That's a good question also. So anytime we see LCIS on a biopsy, and LCIS is often found just by chance. It's not something, right? It's not something that we see on imaging. DCIS often leaves little calcifications. It leaves little footprints that we can find. LCIS and lobular carcinomas too, they're much harder to see on imaging. So LCIS, like I said, is often found by chance. And when it's found, it's always excised. It's always removed. Yeah. Because there's about a 15% chance that right next door, there could be a carcinoma, an actual cancer. That being said, LCIS is not considered precancerous.
Oh, I see. So okay. If it grew, let's say if it grows, it still grows as LCIS.
Right. So LCIS functions more as a marker to say, oh, look, this breast made these abnormal lobular cells. This is a marker that these breasts actually, because if you have LCIS on one side, the risk of breast cancer is the same on both breasts. So it's really just a marker. Okay. It doesn't mean that if you leave it there, it's necessarily going to turn into a breast cancer.
I see.
Okay.
Yes.
So so when we see DCIS, for instance, the ductal type, and we remove that, we want to see negative margins all around that. For LCIS, we don't do that. We don't go back for negative margins. We just want to know that there's not a cancer where that biopsy was.
Okay.
Does that make sense?
Yeah, it makes sense.
It's confusing.
No, it makes sense. It's just everything is just so, overwhelming. One final question and we'll move on. Since lobular and LCIS are very difficult to find in imaging, and I'm very pro follow-ups, 6 months follow-ups. I'm not against it at all, but I'm just curious. What if I do my imaging as good as I can, and then they can't find anything because of the shape and the type of cancer or of the cells in the case of LCIS? What's the point? I know my question is
the point? Oh, so the answer to that is just because you have LCIS does not mean you're going to make a lobular cancer. So lobular carcinomas are quite rare. Only about 10 to 15% of breast cancers that we see are actually lobular in nature, meaning it starts in those lobules that make milk. Mm-hmm. Most breast cancers start in the ducts. Yeah. So that's why, it's not that lobular carcinoma invisible. They're just they're harder to see, but you still should have your imaging because it will pick it up. And like I said, it is 85% of the time, it's a ductal carcinoma that women have.
Changing the subject a little bit. I'm so curious to talk with you about some myths that exist around breast cancer and what causes it. And I know that deodorant, like don't wear it, even having a mammogram or having a biopsy, I've heard more than I would want to, will cause breast cancer because of radiation, or in the case of the biopsy, I think because it spreads the cells. I mean, something like that. So would you tell us more about those myths?
Sure. There's a lot of myths out there. I actually give a talk on this. Awesome. So I'm going to look up a little bit because I have some of the myths that I have. So mammograms. I get that question at least 10 times a week in my office. Do mammograms cause cancer? My aunt told me her mammogram caused her cancer. There's absolutely no evidence that mammograms cause cancer. Mammograms are life-saving. Okay? That is my biggest message anytime I go and do a public health talk, is to tell women that mammograms are life-saving. So we have seen a decrease in the mortality rate of breast cancer of 40% since 1990, which is a massive decrease in mortality, meaning how many women die. And that's directly correlated to how much better mammograms have gotten over the years. And now we have the added benefit of 3D mammograms, which make it even easier to see through the breast, and have actually decreased the number of biopsies. So not only are they increasing the number of cancers that are caught, they're decreasing the number of biopsies. So skipping a mammogram every other year would miss 30% of the cancer that has been found, 30% of the cancers that are found. So that's what I got to say about mammograms. They are very, very important. They're the most powerful tool we have to battle breast cancer and find the disease early so that we can provide cures.
Awesome.
So other myths that I've heard, so deodorant.
Yeah.
Deodorant gets a bad name.
Yeah.
There's no hard data that deodorant causes breast cancer. The thought behind that myth is that there's aluminum in breast cancer, and that the aluminum can cause like an estrogen-like hormonal reaction or go in and clog the lymph nodes. There's been no study to show that. That being said, if my patient is, concerned about aluminum and would rather use a natural deodorant, go for it. I have no issue with that. Absolutely. Right? So that's kind of my message with a lot of these things. If it's something that causes you pause and feels like you shouldn't be putting it in your body, then don't. What I have issue with is when a young woman comes in with a new diagnosis and blames herself because she did something. For instance, I remember a couple of years ago on a popular celebrity's blog, they very popular celebrity put up an article about underwire bras causing breast cancer.
Right.
And there's absolutely no such science to show that at all. And I remember being angry about it. And my husband said, well, what's the big deal? And I said, the big deal is that I assure you in 2 weeks, somebody's going to come in saying, I've been wearing an underwire bra my whole life. This is why this happened. And that's exactly what happened. So it's not necessarily that these myths can hurt people, a lot of them. It's the beliefs that it's our fault that something happened. Yeah. With a lot of them. Except mammograms. Mammograms you got to get.
Because again, like you were saying before, we are eager to find an answer, right? And usually that answer goes back to us. We did it. We caused it.
It's my fault. I should have done this. I shouldn't have done that. And the truth is, it just doesn't work that way. It's not one factor that would cause something to happen, and certainly not the type of bra you wear. Let's see, other good myths. All breast cancers are genetic. Yes. Most breast cancers are absolutely sporadic. 85% of women who have breast cancer have no family history of breast cancer. I also get women who come in who are older who say, but I'm too old for breast cancer. I thought this doesn't happen. And the truth is that our risk increases exponentially as we age.
Yeah, exactly.
But that being said, we're still seeing, like we talked about earlier, a lot of younger women being diagnosed. And oftentimes younger women have more aggressive forms of breast cancer. So again, everything circles back to mammograms. It's just so important. Let's see, what are some other good ones I've heard? Men can't get breast cancer.
Yeah.
Men can absolutely get breast cancer at a much lower rate than women because they have less breast tissue. But it's very important for men to be educated on the signs to look for. When men present with breast cancer, they often have the least aggressive form of breast cancer, but it's oftentimes a later stage because they've either ignored it or thought that can't be what this is. So that's a big public health push too, is to get men to recognize those things.
Do you have anything on biopsies?
Biopsies, I get that a lot too. So breast cancer is not the kind of cancer that can move with a biopsy. Certain types of cancers are, and those cancers we never biopsy. For instance, there's certain kidney cancers that we never do a biopsy of because it can track, and pancreatic cancers, we don't do that through the belly because it can track. So yes, that type of thing exists. It does not exist with breast cancer. It's just not how it works. So a breast cancer biopsy will not spread your breast cancer, but it will identify it, and then we can treat it and hopefully cure it.
What else do you got?
What else? Let's see.
One or two more.
Let's see. Breast pain. Breast pain is a good one. So breast pain is something that I see a lot in my office. Women will get sporadic breast pains. They panic. They think that this is, absolutely the sign of breast cancer. It is very, very uncommon for breast cancer to present as breast pain.
Yeah.
Breast pain is extremely common. About 70% of women experience breast pain in their life. It's more common in the left breast than the right. We don't know why. And like I said, it's not often a sign of breast cancer. That being said, if you see a change, if you feel something, if you're concerned, it's always best to get it checked out. My point in bringing that up is that just because your breast hurts doesn't signal a cause for panic.
Yeah.
Right?
And the same with a lump. If you feel a lump, does not mean you have
it does not necessarily mean that you have breast cancer at all. But that should certainly trigger you to get to your doctor, get the appropriate imaging and the appropriate workup to make sure that it's not.
Yeah.
Let's see, what else? This one I've heard a couple of times from patients, that abortions can cause breast cancer. And this was something that was floating around in the community. And there's absolutely no link between having an abortion and breast cancer. There was actually a big study in 2003 by the American Congress of Obstetrics and Gynecology that proved that there was no link. So,
since you're talking about that, what about the birth control?
Birth control. I get that a lot. So if a woman has a breast cancer diagnosis and they are estrogen progesterone positive, we ask them to stop their birth control and to use a form of non-hormonal, either a copper IUD or a diaphragm. That being said, taking birth control has such a minimal increased risk that it's not considered a risk factor for breast cancer. We can't say absolute zero, but it's almost absolutely zero correlated with a breast cancer diagnosis because it's so low.
Good. That was something I've been told as well. There's just so many. The imagination of people just goes places.
Especially, things are scary and people get scared.
Yeah.
So,
to wrap up, would you like to tell us some more about Evolve Pink? Is there anything we left out? Well,
we're working on establishing our first Thrivers Lounge. So we've rented this beautiful space. We're in Flemington, and we're going to outfit it really beautifully as a women's lounge where women can kind of come, commute, set up their laptop. Everybody's working from home these days, so they can go there and relax, have a cup of coffee, and work out of the house for a little bit. We'll hold guest speakers there, all kinds of things we're going to do there. So that's what we've been working on this coming up. We'd like to reach whoever we can reach, whoever we think, anyone who thinks that they could benefit from this, we're available. We're not limited to just women who've had a diagnosis. We also include high-risk women because so much of what we do impacts the rate of diagnosis, nutrition, exercise, education, all of those things. So anybody with LCIS or anything like that is welcome.
Thank you. And I can guarantee you, once we find that out, we are as scared as someone with a breast cancer diagnosis.
I know.
The questions are there.
They're there. Yeah. It's almost in a way more difficult to navigate because you don't have an answer. It's just, you just know that you're of increased risk and you're given options and you kind of have to make a decision. So I get it. It's a difficult thing to navigate.
Yes. But this was so enlightening. I feel so much better, even about the tamoxifen. Maybe I'll give it a try.
It's not so bad.
All right.
All right.
Dr. Jen, this was a pleasure. You're amazing.
My pleasure. So are you. My pleasure.
Thank you. Bye-bye.
Take care.
And that was our episode for this week. I hope you enjoyed it, and I hope you were able to take away some useful tips and tools to use in your own life. Don't forget to subscribe to Mind Bloom the podcast anywhere you stream your podcasts, and please leave a message on the Anchor FM voicemail if you have any questions or comments for me. Also, please leave a review on the Apple Podcasts app. That would help the podcast reach more people. That would be great. Follow Mind Bloom on Instagram, Facebook, and Twitter at MindBloomU, and check out my website, mindbloomu.com. Don't forget, a new episode every Tuesday. I look forward to spending time with you again next week. Be well and stay blessed. Bye-bye.